ambulance come because of traffic jam, not quick, comes quickly. So 3 hours and 40 minutes after onset. When he arrived, MMT3 and as I explained, left side weakness, numbness, and NIHSS 5. So not too slight, not so severe, especially, but more than 4 considered TPA. And take CT scan. Retina. Do you know aspects? Yeah. Actually, there is an old ischemic here, not acute one, this patient. So we can say aspect 10. So without ischemic, acute ischemic, but no big ischemic change by imaging. So very good indication TPA. So all area seems penumbra. So we explain and finally patients agree TPA and we prepare. Prepare takes a little time and almost 4:30 deadline, but 4 hours 23 minutes we can start successfully. So very good time. So we follow guideline. This is actually first case we follow strictly guideline. And actually after TPA patients recover very well. First NIHSS 3, 30 minutes later 5 to 3 improve. And MRI after TPA finish, we found very small ischemic change, white one. And ICA, neck area ICA very narrow. And also MCA cannot see clearly, but blood flow maybe decanalized. I think this narrowing causes M1 occlusion. This area of some clot, then blocking, but recovering now this time. So actually this patient 1 week later NIHSS is 0, completely normal, recover, and we do stenting, next stenting for this patient. So very good recovery. Sorry, I no time to change English or Japanese. Another case, 69 years old male. This is, we don't know the onset time. In Japan, 2012, so before I come here, we don't know the onset, but when he wake up, he has left weakness completely. Then she has a heart problem, atrial fibrillation, so without cardiac embolization. Then we take MRI. This is we can say 1 point decreasing aspect. I write aspect 7. This slide we can say maybe 10. Maybe we check this area at that time, sorry. And MRA shows M1 occlusion. I didn't perform perfusion MRI, so not follow the guideline. But we imagine it within 8 hours because no aspect problem. So we go mechanical thrombectomy. This time we have a Mercy catheter, so corkscrew type, origin first type 1. Angiography showed M1 blocking here. So we insert catheter, try to recanalize, check the size, and choose the size of Mercy. You can see this black cork on the clot area. 1 time cannot pass through. 2 times we can see very small here, cannot pass. Then we put some urokinase, some diluting, similar to TPA. We put some medicine to recanalize. This time we finish this one, so not completely recover until this one. So middle recover like this. M1 can recover, but M2 both cannot see. After CT, some small bleeding on the ischemic area. Next day. MRI next day. So actually we cannot save all area, but we can save, for example, this area by this treatment. And MRA show next day, so one artery we can save, recover. One still blocking, but without treatment maybe this all blocking and patients cannot recover well. So these patients can walk by stick, so modify ranking scale 2. So very good cases. So even recanalize, not recanalize all, but was to try. And also I should inform. So basically brain vessel is connecting together. Very small area, but connecting. So even one area blocking, very lucky patients, this connecting area support all. So some case even blockage and have symptom first, but gradually improve without any treatment because this supply, we call collateral supply, other supply become more helpful. In that case, no need to do treatment, of course. And we don't know yet which patients have no connection or which patients have rich connection. So that's why we have to check perfusion MRI. Perfusion can show the blood flow in the brain. So if the collateral supply very rich, perfusion don't have any penumbra and no indication recanalization. So even after angiography, this case, 74 years old male, left side palsy, right side MCA very small intensity, aspects maybe 11, 9 or 10, and M1 occlusion. But this patient's first MMT1 completely palsy, but recover to MMT4. So we check angiography and still M1 occlusion, but you can see M1 occlusion, but from ACA or PC, mainly from ACA. This is PCA, also PCA support all area. So this patient is very lucky. So no indication recanalization. So just diagnostic check and we finish. So it's already time. So final topic. So one more thing. Even the symptom is like stroke, like fast palsy or cannot speak clearly. There are several other diseases like we call mimicking stroke. Do you know chameleon? Chameleon in English. This is some animal. Mimic. Thief. Not dinosaur. Real animal. Sometimes in Japan we call chameleon, stroke chameleon, like mimicking. So this study check the mimicking stroke. Number 1 is brain tumors. Number 2, hypoglycemia, toxic hysterical attack means psychology problem. Seizure, sepsis, subdural hematoma. This is maybe main common. Another one, hyponatremia, very common in Cambodia. I don't know why, but yeah. So of course, suspect stroke is important. Check glucose, CT scan, or anything. But if not stroke, we have to survey more, consider other than stroke. So if CT scan don't notice anything, maybe we take MRI, we check other blood tests as a next step. Okay. So it's all time 7 o'clock, so we finish. So today I share the acute management of ischemic stroke mainly, so please remember about it. Any questions? Yes.
Because I'm not the medical staff, so I'm not really understand about it. I have some simple questions. One is I want to ask: is stroke? Who is the victim of the stroke? Like, is stroke can happen to the children or young people? And the second question is, is the head like you have accident or fall down from somewhere high and affect your head? Is it cause the stroke? And another question is that if the stressfulness can cause the stroke, because I see in Facebook a few days ago they said that one very beautiful woman got died because of the stroke and stressfulness. So one more question is because we all have our relatives and we all want to take care of ourselves. So can you recommend some simple way that we can avoid stroke?
Okay, thank you. Yeah, sorry. Prevention maybe deeply. I explain next another lecture. So the most risk of stroke mainly the diabetes, hypertension, smoking, or hyperlipid, hypercholesterol. So this all often happen for adults. So sudden blockage of vessel is stroke. So also children also happen. It's not common, but it happens. For children case, it's not like diabetes or anything. Maybe some congenital since they are born. Vessel is very weak, like moya disease, which means vessel very narrow, and then easily becomes stroke, or some lupus. Lupus is a skin rash or joint pain, also vascular leak. So some other cause underlying. In that case, also children have stroke. So basically for adult stroke prevention, mainly if patients smoking, we should strongly recommend to stop smoking. It's a good chance. So like when OPD, some other similar question almost every day, patients or family ask me. And if the patient don't smoke but family is smoking, so we should inform them to stop smoking and manage risk factor. So hypertension, diabetes. Also, if there is a heart problem, also stroke risk, so evaluate heart. Can I answer all? Stress? Stress, yeah, stress increase hypertension, blood pressure increase. So stress is also the risk of stroke. Some doctor says even though hypertension stress itself causes stroke or heart attack, we don't know if it's really true or not. The better to avoid stress. And trauma is different. So
About it, like you fall down from.
yeah, head attack, not stroke. So damaging cause bleeding outside. Usually we don't. It's not the cause of internal vessel bleeding. Another. Yes.
Could you back to CT scan on
Yeah.
the
Any mistake?
one say for the outpatient clinic in the I cannot recognize it. Actually, score 10 by 10, so yeah, 10. And how to it mean how to evaluate the after score 10 spot?
Yeah. Okay. So there is a place. So there's 10 point, 10 place. So this rise M1, M2, M3, I, L, C, I, C. This rise 3, M4, M5, M6. So for this M1 black, so minus 1 point. M2 also minus 1 point. M3 okay. C minus, L minus, IC maybe okay, no minus. On this side, M4 not minus, M5 minus, M6 okay. So from 10 we minus this point, then become 4. Sometimes like M4 plus or minus, sometimes change, maybe according to the evaluator. So like that. So this one, actually this is black one. So we can say 9, but this is completely old one. We understand by CT scan, not the acute one by images. So I say 10, no escape. We can say 9, we can decrease this.
It's the same thing. So I compute 10, it means more serious.
No, 10 full, no problem. 0 serious. You have to know. You have to teach us. Yes.
So I have a question for TIA patient.
Yeah.
So after 2 hours recover and come to OPD for support, so need to get ER treatment, emergency treatment, or just normal?
Next lecture. Yeah. The answer is if no risk, it's okay, go home. But if diabetes or TIA period very long, we recommend to be hospitalized. It's the same as stroke, very high risk of stroke. There is some score, A, B, C, D score, age, blood pressure, C, D, there are 2D, duration, diabetes. C, maybe cholesterol. Cholesterol. Sorry.
So if no more,
If no hypertension, so ABCD score 0 or 1, it's okay to go home. But if OPD case, maybe every case better to go ER. Or if doctor is available, quickly see doctor. This is better.
Thank you for good presentation and one question about the ischemic stroke. Why is how the limb and what is affect that? And other one the lymphadenopathy in the blocking or other part of the blood.
Bleeding.
Yes.
After ischemic.
Yes.
Yeah. Okay. Yeah, after ischemic, for example, this catheter treatment, bleeding happen. So this area bleeding, this patient. This area is ischemic. So ischemic area already brain died. So, but this patient decanalized. So brain tissue die and blood come. So bleeding happen. So the high risk of bleeding after ischemic is if big area is ischemic and decanalizing, the bleeding happen.
That means the result is blocked and
Yeah, so like this case, this patient decanalizing already. So this is good thing to save this area, surrounding area. But the bad effect of decanalize is high risk of bleeding. That is, blood is coming, already dying, then bleeding. So that's why we have to check aspects. If the ischemic area already big, there is no reason to decanalize, only the risk of bleeding. So we shouldn't try to decanalize. One ICU patient, very big MCA infarction with bleeding. So this case may be decanalizing already. And if we do strong treatment, maybe only the risk of bleeding. No reason to decanalize, already damaging. So have to control blood. High blood pressure also risk. Okay.
yeah.
One more question.
The first one, acute stroke. After we do TPA, is it necessary to do diaphragmatic dose? Yes. And another one, if we have ischemic stroke and then we have a hemorrhage, so how we manage it?
First question, after TPA, we should do duct or not?
Yes.
Okay. Sorry.
Diaphragmatic dose.
Yeah. After TPA, but still acute phase, we can consider medication therapy. We should consider. So for antiplatelet therapy is the next step, or if no indication of TPA intervention. So basically, starting dose better to use duct. Starting not enough, only 100 or 81 aspirin. Our hospital have 100. Clopidogrel 75 is not enough. So generally not associated with TPA. Better to start duct. Otherwise, not effective. So 24 hours after TPA we cannot. But after 24 hours, to prevent next stroke, duct is good. So duct means dual antiplatelet therapy. So every time starting, better to use double. But it depends. So duct is good for prevention, but the high risk of bleeding. Not only loading dose or single dose. So if already have massive damaging, maybe we recommend single dose, or we recommend not to do loading dose. So it depends the patient's risk and benefit. We will discuss. What's the second question?
Like patient has ischemic and then hemorrhage. So how we know?
Yeah. So it's also similar. So to prevent further stroke, maybe some antiplatelet, or if heart is coagulation, warfarin is necessary, but it's a risk of bleeding. So generally, acute bleeding phase, we stop all medicine. 2 to 3 weeks, we stop. And after 2 to 3 weeks, we start again. But there is no answer. If vessel very narrow, very high risk of stroke again, and bleeding very small, maybe we start antiplatelet or anticoagulation soon, carefully.
And so another one like how about some acute stroke? We have to do double things.
Next lecture. The acute stroke. Okay, sorry, thank you very much.
Thank you.
So don't forget to register. Thank you.
Một cô trong ca gì? Ở hiện chỗ.
Very high risk by diabetes. If low risk loading dose better. Anytime better to use loading dose. There is a risk of bleeding, but the benefit for acute stroke. Subacute or chronic, maybe same. So 2 to 3 days later, density become normal. So I think loading dose not becoming already chronic. But